Good afternoon, good morning, or good evening to all of you, and welcome to this webinar on the importance of phosphate homeostasis throughout life. I'm Dominique Pierrot, Science Manager at IOF, and I'm glad to moderate this webinar today. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker towards the end of this webinar. I also would like to warmly thank Kiowa Kirin for supporting this webinar. And now, this being said, I have the great pleasure to welcome today Dr. Gemma Marcucci, who is a research fellow in endocrinology at the Bone Metabolic Disease Unit, Department of Biomedical, Experimental and Clinical Sciences at the University of Florence in Italy. She is a scientific investigator involved in several clinical trials about osteoporosis medications and rare bone and mineral diseases. Dr. Marcucci, it's a pleasure to have you today, and we are listening to your lecture.
Thank you very much. I am pleased to present this webinar. The main goals of this webinar is to review the role of phosphorus and to recognize the clinical and biochemical features of, in particular, phosphate wasting disorder, to describe the principal diagnostic criteria and the past and new treatments for these disorders. We know that phosphorus is an important structural constant of bone to form calcium and phosphate hydroxyapatite. It is essential for cell metabolism and energy regulation. It is important for nucleic acids and cell membrane, and it is important for acid and base homeostasis. The diet is the primary source of phosphorus, of body phosphorus. Many foods are rich of phosphorus, especially dairy products, meats, and vegetables. So, excuse me. So in this table, you can see the recommended daily allowances of phosphorus daily. You can see that in a childhood, the RDA of phosphorus is high in a particular period during the skeleton, in particular during the skeletal development. In adult subjects, the RDA is equal to 700 milligram of phosphorus daily. We know also that in specific physiological conditions, such as pregnancy or lactation, there is not necessary to increase the RDA, because we know that during pregnancy there is a increase of intestinal phosphate absorption, and in particular during lactation there is a increase of bone phosphate resorption, and also increased intestinal phosphate absorption. So, intestinal phosphate absorption is regulated by two mechanisms: a passive pathway sodium independent mechanism and a active sodium dependent mechanism. Thanks to these co-transporters of phosphate, sodium phosphate type 2b. The active mechanism of intestinal phosphate absorption is important, in particular in case of fasting and in case of low phosphate intake with diet. Intestinal phosphate transport is regulated by, of course, dietary phosphate intake, and then by levels of active vitamin D. Of course, high phosphate dietary intake and excuse me, because okay, I have a problem with, okay. So we know that intestinal phosphate transport is regulated by dietary phosphate intake and levels of active vitamin D. So low dietary phosphate and high active vitamin D levels, we know that stimulate phosphate absorption through these sodium and phosphate co-transporters type 2b. Most of phosphate is found in the skeletal, and lower percentages is present instead in soft tissue and in extracellular fluid. So the skeletal represents the largest reservoir of phosphate, and also we know that is an important source of the major hormone that regulates phosphate transport. Then everyday phosphate is deposited in bone formation and is removed by bone resorption thanks to the bone remodeling process. Kidney represents the primary organ that control phosphate concentration in the circulation. We know that proximal convolute tubule is the major site of phosphate reabsorption. There are two important sodium phosphate co-transporters at the kidney, and the rate of this transport depends on the number of these transporters. And the sodium and phosphate ATPase in the basolateral membrane generated this sodium gradient. So kidney is an organ very important to control phosphate concentration and renal phosphate excretion. The renal phosphate reabsorption is regulated by, of course, dietary phosphate intakes and this hormone, PTH, FGF23, and active vitamin D. We know that PTH results in a rapid endocytosis of these and the degradation of these sodium and phosphate transporters, and appears to be an acute effect. Vitamin D appears to have a permissive role of the action of PTH on phosphate reabsorption. And now let's start to to talk of the most important hormone that regulate phosphate, that is FGF23. FGF23 is a phosphaturic hormones, together other hormones, but this is the most important. It is this hormone is a glycoprotein with 251 amino acids. It's primarily secreted by osteocytes and osteoblasts, and we know that under physiological conditions, this hormone is almost exclusively produced by osteocytes and osteoblasts in response to high serum phosphate levels and active vitamin D. This figure summarizes the principal canonical and non-canonical effects of this hormone. So we know that FGF23 binds its receptor type 1C in presence of its cofactor called cloto, and at proximal renal tubule, FGF23 is able to cause internalization of sodium and phosphate transporters type 2A and 2C, and it is able to reduce phosphate reabsorption. Then it is able to inhibit 1-alpha hydroxylase and reduce active vitamin D synthesis. Then we know that at distal renal tubule, FGF23 is able to reduce calcium and sodium excretion. Then recent studies showed other non-canonical effects of FGF23, such as the effect on PTH secretions. This hormone appears to reduce PTH secretion, reduce bone mineralization, inhibiting these enzymes, alkaline phosphatase, and appears to increase left ventricular hypertrophy. So serum phosphate and active vitamin D are both positive regulators of FGF23. And active vitamin D, we know that can increase FGF23 secretion, and PTH increases FGF23 secretion. So there is this feedback mechanism. Then we know also that low iron status can increase FGF23 secretion via non-endocrine mechanism. But in addition, there is also factors produced locally in the bone that have a role in FGF23 regulation. For example, the MP1 can inhibit this hormone. Instead, MEP has a opposite effect to the MPE. Then there is the role of FIX that we will talk in the next part. So, in pathological condition, we can find a status of hypophosphatemia. Serum phosphate concentration in this case is lower than 0.8 millimeter liters in adult subject. And the initial steps to understand the cause of hypophosphatemia is to understand if hypophosphatemia is caused by an increased renal excretion, or there are other causes such as impaired intestinal absorption, transcellular shifts, or the use of other drugs. So we will focus on this group of disorders. This group of disorders is disorders caused by an increased phosphate renal excretion with a FGF23 mediated mechanism. When we find a status of low serum levels of phosphate, we should to measure serum levels of PTH. In case of high levels of PTH, the cause could be a common form of primary hyperparathyroidism or deficit of calcium or active vitamin D. In case of normal or low levels of PTH, we should to measure urine levels of phosphate. In case of hyperphosphaturia, it's useful to measure serum levels of FGF23 if available, and in case of high level of FGF23, this alteration can suggest a form of genetic hypophosphatemic rickets or a form of acquired hypophosphatemic rickets due to high levels of FGF23. In case of normal or low levels of FGF23, we can think to a form like hereditary hypophosphatemic rickets with hypercalciuria or Fanconi syndrome. In case of low levels of phosphaturia, the causes can be other disorder, such as decrease in gastrointestinal absorption of phosphate. To investigate phosphate wasting disorder, it's important to calculate this ratio, TMP-GFR, tubular maximum phosphorus on glomerular filtration ratio. In case of if this ratio is low 2.5 milligram deciliter, this is a pathological findings, and it is associated to this phosphate wasting disorder. This ratio can be calculated using this nonogram or these mathematical calculations. So, start to talk XLH. XLH is X-linked hypophosphatemic rickets. Among these rare disorders, we can say that XLH is the most common. The cause, this disease is caused by a mutation in a fixed gene. Fixed gene usually encodes this endopeptidases, and it is expressed in osteoblast, osteocytes, and T. Mutation of this gene cause high FGF23 circulating levels. The diagnosis of XLH is based on clinical, radiological, and biochemical findings. And as recommended by the recent consensus statement on XLH, it is important to confirm the clinical diagnosis of XLH with the analysis of a fixed gene. If genetic analysis is not available, elevated levels of FGF23 and or a positive family history for XLH support this diagnosis. Clinical manifestations of XLH is very variable. Usually, this manifestation starts at childhood with delayed and disproportionate growth, craniosynostosis, rickets, delayed motor development and gait abnormalities. Then there are some clinical manifestations present both in pediatric and adult age, such as short stature, deformity of weight-bearing limbs, odontoiatric complication, osteomalacia, bone and joint pain, joint stiffness, muscle pain and weakness, and clinical manifestation typical of the adult patients include fragility fractures, osteoarthritis, extraosseous calcification, hearing loss. In general, there is a reduced quality of life in these patients. So considering the effect of FGF23, in this patient there is a high level of FGF23, and so it is easy to understand the biochemical alterations that we can find in XLH, but also in these other rare form of hypophosphatemic rickets. So we can find hypophosphatemia, hyperphosphaturia, low levels of TMP on GFR, levels of FGF23 high or inappropriately normal compared than the status of hypophosphatemia. PTH calcium can be normal, but we know that these subjects affected by this disease have a high risk of secondary hypoparathyroidism and tertiary hypoparathyroidism, caused by especially the chronic phosphate supplementation, and is due to low level of active vitamin D, because FGF23 we know that inhibits active vitamin D. So what is the standard, the conventional treatments of these disorders, XLH, but also these other disorders? The phosphate treatment, the conventional treatment, is based on the use of phosphate supplementation and active vitamin D. So this conventional treatment, this treatment with phosphate and calcitriol became the standard therapy from the 80s. It is important to start early this treatment. Initiation of therapy at early age is recommended and result in improved the growth of the skeleton. But however, we know that correction is limited, and we know that conventional treatment is not able to resolve all clinical manifestation because FGF23 remains high. Moreover, we know that this treatment is associated to a difficult adherence, and often there is frequent gastrointestinal side effects. Here we can you can see the doses recommended in case of conventional treatment in children. And instead, regarding adult patients, it is still open the debate on conventional treatment for adult patients, because it is not clear when conventional treatment should be recommended. So this recent consensus statement suggests to consider conventional treatment in adult patients in case of symptomatic patients, okay, and also in case before a orthopedic surgery, or in case of pregnancy or lactation. and this is the doses recommended. And then this is the table that summarize the suggested follow-up for children and adults treated and non-treated with treated and non-treated. And the follow-up include a monitoring of clinical manifestation, biochemical exams, and imaging exams. A careful monitoring is required to avoid hypocalcemia, hypercalciuria, and secondary hypoparathyroidism. So it's important. And because a close monitoring is important, because the conventional treatment, we know that it is associated to renal complication, such as nephrocalcinosis, kidney stones. And the limitation and the complication associated to chronic treatment with phosphate supplementation and calcitriol. So this limitation, this complication has been described very well in this survey that has been published recently, and both in pediatric and adult patients. But now let's start new treatments. Scientific research studied a new drug called burosumab. Burosumab is a human recombinant monoclonal antibody that it is able to bind FGF23, and it is able to inhibit its effect. And so this drug is able to reduce phosphatiuric effect by FGF23. Recently, the results derived by this randomized active controlled open label phase 3 has been published. This trial showed the result in terms of efficacy and safety of burosumab in pediatric patients compared to a group treated with conventional treatment with calcitriol and phosphate supplementation. So this trial showed that burosumab is able to normalize serum phosphorus levels quite rapidly, and also normalize the ratio TMP-GFR, and active vitamin D remains within normal range. And in particular, this trial showed how burosumab was able to improve rickets score, and showed a significant improvement in terms of motor function measured with the 6-minute walking test. Fortunately, no severe adverse events were described. This studied a trial in adult patients. This article published the results derived by this randomized double-blind placebo-controlled phase 3 trial. In this case, burosumab was confronted with a placebo group. The patients were adult and were affected by a severe form of XLH. The primary endpoint was to normalize serum phosphate levels, and most of patients treated with burosumab showed a normalization of serum phosphate levels at the midpoint of dosing interval, because in this case burosumab was administered every 28 days. Okay, and then also serum phosphate levels were normal also at end of dosing interval, quindi after 4 weeks. Then this trial showed a improvement of ratio T and PGFR, initial rapid increase of active vitamin D, then showed a decrease, but however at the end of the period of study at 24 weeks, active vitamin D was normal. This trial also showed a significant improvement of WOMAC stiffness scores, and a improvement but not significant scores of BPI and WOMAC physical function. Then showed a improvement of fractures Elling, an initial increase of bone turnover markers, and after the first period showed a tendency to decrease bone turnover markers. The initial increase suggests a normalization of bone turnover process. No serious adverse events were described, and also PTH levels resulted reduced until 24 weeks. Then other result has been published, so we can see also this article that published the result derived the extension period of a clinical trial. So this trial confirmed the good outcomes until 44 weeks of treatment, and the last article published is this that shows the results until 1960 weeks of treatment. In these two last article, we can see a significant improvement of WOMAC scores and BPI, BFI in over this period, maintaining serum phosphate normal within the normal range. Thanks to these good results in terms of efficacy and safety, recently burosumab has been approved to treat XLH in pediatric patients and in the adolescents aged 1 to 70 years with radiographic evidence of bone disease, and in adults. However, we know that in not all countries this treatment is not in all countries is possible to use this treatment, in particular for adult subjects. The recent consensus statement recommended to consider burosumab treatment in adult patients in case of symptomatic patients. Okay, so the doctor have to evaluate if it's the case or not in base considering the clinical manifestation and the control of the disease. However, further studies need to be performed to evaluate the long-term efficacy and safety of this burosumab, because we have data only until 96 weeks of treatment. So we can also remember some other phosphate wasting disorder, like autosomal dominant and autosomal recessive hypophosphatemic rickets. They are rare disease. They present high levels of FGF23 levels, but they are caused by different genetic mutations. Biochemical alteration is similar to XLH. The autosomal dominant hypophosphatemic rickets has a age at presentation that can vary between childhood and adult, because there is not a complete penetrance. Clinical manifestations are similar to XLH, but we have to remember that most patients who develop this disease in adulthood are women, and of course in specific moments, stress conditions, for example, during pregnancy, probably there is a role of low iron status. Then there are these two forms of autosomal recessive hypophosphatemic rickets caused by two other gene mutation. Then we have to remember a form of hereditary hypophosphatemic rickets with hypercalciuria, but this disorder is not FGF23 mediated. The gene mutation is a different mutation. There is no high levels of FGF23 levels, but the problem is at proximal tubular renal. The problem is at proximal renal tubule. And there is a state of hypophosphatemia, hyperphosphaturia, and hypophosphatemia cause a high level of active vitamin D, and this can cause hypercalcemia and hypercalciuria. So in this case, it is not recommended calcitriol therapy, but only phosphate supplementation. To conclude, I would like to talk of another rare disorder called tumor-induced osteomalacia. TIO is a rare paraneoplastic syndrome characterized by hypophosphatemia due to renal phosphate wasting and osteomalacia. Hypophosphatemia in this case is caused by unregulated oversecretion of FGF23 derived by small mesenchymal tumors. The principal problems, the main challenges of this disease is to find these small mesenchymal tumors, perché in some cases it's very difficult to find these tumors that are the cause of these disorders. So also in this case, we have high levels of FGF23 And so the biochemical alterations is similar to other disease described before. In TIO, we can have decreased TMP-GFR, hypophosphatemia, hyperphosphaturia, low levels of active vitamin D, normal levels of serum calcium, PTH, and cholecalciferol. This biochemical alteration can cause a defective mineralization, osteomalacia, bone pain, fractures, and muscle weakness. So this is the principal clinical manifestations. It is similar to other described disorder, but it is a acquired form. It is not a genetic form. We have several imaging exams that we can use to find this tumor, but however, it is not easy. So the goal treatment of TIO is the surgical exportation of these tumors, and so this therapeutic approach resolve the problem, but in case of not remission of the pathology, in case of recurrent, or if I don't find this tumor, we can however use the medical treatment with phosphate and calcitriol. And also in this case, is important a close monitoring of biochemical exams to avoid calcium phosphate oscillations. Then also in this case, we have a trial in which burosumab has been used. So this article has been recently published. It shows the results derived by a two-phase open-label trial assessing burosumab efficacy and safety in patients with TIO. And this trial conducted in a small group of patients, adult patients, showed the effect of this drug in a period of 120 weeks, and showed that burosumab was able to normalize serum phosphate, maintain normal levels of active vitamin D. Also in this case, there was initial increase of alkaline phosphatase, and then this marker tended to reduce. Also showed the improvement of brief pain inventory score, 6-minute walk test, improved the fracture healing, and also in this case, fortunately, no severe adverse events were described. However, also in this case, the long-term efficacy and the safety will be needed to be considered. And so burosumab has shown good outcomes, but in future further studies will be necessary to confirm long-term efficacy and safety. With this slide, I conclude. Thank you very much for attention, and I am pleased to answer some questions. Thank you very much.
Okay. Thank you very much, Dr. Makuchi, for this very comprehensive presentation on the importance of phosphate and on phosphate wasting disorders. The topic was broad and there were many aspects covered during this presentation. And I'm sure that your talk was greatly appreciated by our audience. Now I would like to move on to question as we have received some during this presentation. So maybe I'm going to ask you the first question, which is what are the normal age-dependent values of serum phosphate?
So I have also a slide. In this table, you can see the different normal range values of serum phosphate. The range varies based on age of subject, and then can be some differences between laboratories and laboratories. Depends.
Thank you. Then I have two questions related to pregnancy. So the first one is in physiological conditions, do FGF23 level change during pregnancy?
Okay, so we have only some data derived by studies conducted in animals, rodents, and these studies showed that FGF23 increases during pregnancy, but we have not data in humans.
Okay, thank you. There is another question about pregnant women with XLH. And what does the recent consensus statement recommend for this woman? Is it mentioned?
So during pregnancy, the recent consensus statement recommended to use conventional treatment, and in some cases it's necessary high doses of phosphate supplementation until 2000 milligrams of phosphorus daily. And remembers that it's very, very important a close biochemical monitoring of biochemical exams in these particular physiological conditions.
Okay, thank you. I have another question asking whether fibrous dysplasia can be associated with hypophosphatemia.
Yes, in some cases, in hypophosphatemia is present in fibrous dysplasia within McCune-Albright because there can be a overexpression of FGF23, and so also in this case high levels of FGF23 cause a high phosphaturic effect, and so hypophosphatemia, hyperphosphaturia, etc.
Thank you. I have another question from Dr. Chi-Wu Pan, who is asking if you have already encountered patients with hyperphosphatemia.
So hyperphosphatemia Yeah, we have patients with hypophosphatemia caused by tumoral calcinosis, for example. Is a rare disease that is characterized by not high level of FGF23, but low levels of FGF23. So there is a low effect by FGF23, and so this disorder is characterized by a opposite biochemical alteration. So it is characterized by hypophosphatemia, hypophosphaturia, and it's a disease characterized by extraskeletal calcifications. Then we have patients with hypophosphatemia, of course, caused by hypoparathyroidism. So this is the opposite clinical situation.
Thank you. I'm coming. Yeah. So there is another question, also related to hypophosphatemia. So the person is asking whether hypophosphatemia in either fibrous dysplasia or McCune-Albright syndrome has ever been treated with burosumab. Have you any idea, or have you heard something?
So there is, I think, only an article published on this topic. A child affected by fibrous dysplasia with hypophosphatemia was treated with burosumab, but it's only a case report. However, this child of 7 years old was treated with burosumab because he had a severe hypophosphatemia and clinical manifestation. The treatment with burosumab, the period of treatment with burosumab was 70 months, or almost 70 months, and in this case showed a good control of serum phosphorus levels, phosphate levels, normalization of TMP-GFR, and improvement of clinical manifestation. But however, I am talking of one case report, and so other data are sure, of course, necessary. Burosumab in future could be used in several disorders characterized by phosphate wasting and high levels of FGF23. But however, it's in new drugs, and so several investigation will be necessary.
And because they are rare diseases, it's also not so easy to I suppose to set up a good clinical trial.
Yes.
Okay, so I think it's time to conclude, and I would like to thank all of you for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of this webinar on the IWF website, and you will receive the link by email tomorrow. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments as we continuously try to deliver webinars that meet your needs. I would like to thank again Kiowa Kirin for their support It was really well appreciated. And last but not the least, if you have any questions, comments, please do not hesitate to send them to webinar@osteoporosis.foundation. I would like to thank you again, Dr. Marcucci, for your outstanding talk. And I would like to wish all of you a very nice day or a great evening. And season's greetings to all of you. And I hope to see you next year. Bye-bye.
Thank you very much.
You're welcome.